In 2023, the World Health Organization reported a staggering statistic. Approximately 260,000 women died worldwide from pregnancy-related causes. When we map these fatalities, a stark geographic disparity emerges. Over 90% of these deaths occur in lower-income countries, with roughly 70% concentrated in sub-Saharan Africa alone. Zooming in further, Nigeria stands out as having the highest individual burden. Yet the vast majority of these fatalities share a single critical characteristic. With timely access to quality obstetric care, they are entirely preventable. The persistence of these numbers indicates that global maternal mortality is not driven by a lack of clinical understanding, but by systemic failures in how healthcare is delivered. We first have to establish strict parameters. A maternal death occurs while a woman is pregnant or within exactly 42 days after termination. The cause must be directly related to the pregnancy, specifically excluding accidental causes like a car crash. We separate this from maternal morbidity, which encompasses any health condition attributed to or worsened by pregnancy that negatively impacts a patient's well-being without resulting in death. This visual shows the standard metric to track these fatal events, the maternal mortality ratio. It is calculated by dividing maternal deaths by 100,000 live births, standardizing the measurement of risk across nations with vastly different population sizes. Establishing these rigid parameters allow epidemiologists to pinpoint exactly where national health systems are failing their populations. By applying these metrics over time, we can see that historical progress is possible. The global maternal mortality ratio has declined by approximately 40% since the year 2000. To accelerate this progress, the international community established a strict mandate through the United Nations. Specifically, Sustainable Development Goal 3.1 aims to reduce the global maternal mortality ratio to fewer than 70 deaths per 100,000 live births by the year 2030. Meeting that deadline means moving beyond merely collecting data. We have to deconstruct the exact chain of events that leads to a fatality. The clinical pathologies behind these fatalities fall into two categories. Indirect causes are pre-existing medical disorders, like malaria or HIV, that are aggravated by pregnancy. This classification tree breaks down the direct obstetric complications. At the very top of the direct branch is postpartum hemorrhage, which remains the leading single cause of maternal death worldwide. Right below it are other rapidly progressing life-threatening pathologies. Hypertensive disorders like preeclampsia and eclampsia, severe systemic infections or sepsis, obstructed labor, and unsafe abortion. Modern medicine understands these conditions intimately. Highly effective, standardized treatment protocols exist for every single one of them. If a condition like an obstetric hemorrhage is highly treatable in a clinical setting, its fatal progression usually points to a compromised timeline. This diagram outlines the 3 delays model, used to analyze preventable deaths in low-resource settings. It begins with delay 1, the critical time lost when a patient or family is delayed in deciding to seek professional medical care. This hesitation often stems from poor baseline nutrition, inadequate initial antenatal care, or simply a lack of education regarding clear obstetric danger signs. Once the decision to seek help is made, the patient faces delay 2, the logistical and geographic gap involved in physically reaching a healthcare facility. A lack of reliable transport, deteriorating local infrastructure, and fragmented referral systems severely exacerbate the physical distance between a patient's home and formalized medical care. The most advanced clinical treatments are essentially useless if systemic barriers trap the patient in either of these first 2 delays. Even if the patient navigates the physical distance, they arrive at delay 3, failing to receive appropriate, life-saving treatment at a tertiary care facility. This stage is where acute resource shortages become fatal. Facilities often face a lack of skilled birth attendants, inadequate emergency obstetric care equipment, and a lack of timely blood transfusion services. This flowchart maps the emotive bundle, the clinical countermeasures required to intercept a postpartum hemorrhage. It begins with immediate pharmaceutical interventions, specifically administering uterotonics and tranexamic acid to induce clotting. If the bleeding continues, protocols mandate immediate physical escalation to uterine balloon tamponade, followed by surgical intervention if necessary. Similar, rigorous clinical pathways exist for the other direct causes. We use magnesium sulfate to control hypertensive disorders and aggressive early antibiotics for sepsis. Delay 3 acts as the ultimate bottleneck. If the hospital lacks the supplies or the staff to execute these core interventions, the preceding delays become a death sentence. To proactively fix these health systems, hospital administrators must shift their focus away from just tracking maternal deaths and begin analyzing instances of severe maternal morbidity. This introduces the concept of a near miss, a patient who nearly dies but ultimately survives a severe complication, like a massive obstetric hemorrhage or a uterine rupture. This iceberg diagram visualizes why near-miss cases are mathematically essential for systemic auditing.
Fatalities represent only the highly visible tip. The massive volume of near-miss events, ICU admissions, and emergency peripartum hysterectomies form the wide, hidden base beneath. Because they happen far more frequently, near misses provide a high-resolution data stream. They allow health systems to diagnose their clinical blind spots without having to wait for a fatal event to occur. This shows the Maternal Death Surveillance and Response (MDSR) cycle, an active feedback loop operationalizing data from fatalities and near misses. Staff conduct strict clinical audits and root cause analysis. This directly leads to tangible corrective measures, fixing local bottlenecks. These continuous local quality improvement efforts tie directly into the World Health Organization's broader global strategy, known as Ending Preventable Maternal Mortality. That global strategy relies entirely on achieving universal health coverage and guaranteeing respectful, well-resourced maternity care for every patient. Maternal mortality is the ultimate litmus test of a healthcare system's quality. Hitting the 2030 target requires relentless structural auditing and strict accountability at every single level of care.